Welcome to week 2 of Opiate Crisis 1. This week we're going to talk about prevention strategies. So I've broken this up into really 4 main categories, and then I created a 5th category called other ideas because I certainly don't know all the ideas, but I'll share with you some of the insights that I've developed as I've focused my time and energy on trying to play a positive role in this healthcare epidemic. And I break those up into 4 key categories: communication and education, community intervention, regulation and advocating, and educating and advocating for alternative therapies. And as I mentioned, I know there are other ideas out there, so this is not an all-inclusive, but it's my perspective on some things that can and should be done to prevent people from developing an opioid use disorder and prevent them from dying if they do get an opioid use disorder. So I have a couple of things here that I want to talk about. One is that that each one of us can help with this problem. So we all have skills and tools that can help people that we know, care about, and so I hope that each of us will consider doing something to help others who are afflicted with this problem. And ideally, we might also do things to prevent people from going down this track. The other message that we need to recognize is that this is a health issue. It's a medical issue. This is not a disease of choice like any other disease. It's one that people get but no one really chooses to have it. And so just like diabetes or hypertension or any other chronic disease, people develop this chronic disease called opioid use disorder. Many times, estimates are 80% of the time, people actually start on this path with a legitimate prescription and then can't stop at some point. So let's take a look at some of the prevention strategies that we should consider. So the first thing that I put on my list of prevention strategies is to communicate and educate. The reality is that there are many people who still haven't got the message about the risk of addiction and overdose that opiates create. And unfortunately, and perplexing to me, is that includes healthcare providers. So they either haven't got the message or they're ignoring the message. So we certainly have to put some concerted effort into ensuring that healthcare providers are aware of the risks related to opiate. So I know there's a movement in the educational field and medical schools and others to talk about pain management and excuse me, addiction. And this has all been brought about because of the increasing concern about the overprescribing of opiates to manage pain. So there's a law that's been passed in 16 states, and I've been advocating for it to be passed in Massachusetts and New Hampshire. It's called the Right to Know. The Right to Know law basically legally requires any prescriber to discuss the risk of opiates with people they're prescribing to. So we have dentists, we have physician's assistants, nurse practitioners, and others who prescribe regularly for things that are not related to chronic pain management issues, things like wisdom teeth removal, sprained ankles, etc. We're still vastly overprescribing. And so this law, which has passed in 16 states, requires healthcare providers who prescribe to talk about the risk that somebody who takes an opiate could, in a very short period of time, become addicted to that drug. And if you become addicted to opiates, then you may develop a lifelong chronic disease called opioid use disorder, which we don't have a cure for today. We have ways to treat it, but we don't have a cure for it. So by taking an opiate just for a short period of time, you may be one of those unfortunate people that develops this chronic healthcare disease called opioid use disorder. So that is the first part of the requirement. The second part of it is that the prescriber has to talk about non-opiate alternative treatments. And so I think that this would be an excellent start among all of our healthcare providers, that they that they be required to have that conversation with anybody that they prescribe an opiate to. And there are some exceptions to that need. So, for example, somebody at the end of life, somebody who's being treated for cancer pain, those are acceptable means to have opiate prescriptions. And the American medical profession is not going to allow regulators to step in and tell them what they can't do, but regulators and lawmakers can step in and tell them that they have other obligations. And all of this should be viewed as communication and education. So when we think about other areas that we need to improve our communication and education, certainly educational institutions can play a big role. And I think that's been recognized by and large, particularly among educational institutions that offer healthcare programs. But that said, making sure that we both help inform those who will be future healthcare practitioners, and there's another element here too, which is we should reach into the primary and high school level educational institutions and talk about the risks of opiates and the risk of addiction and overdose, so that younger people start to become aware of it. And I know the communication method there has to be tailored and specific to things that younger people will hear. So one of the key things that we learned in trying to prevent smoking is that one of the things that young people often will do is rebel against authority. And so one of the ads that became most effective in preventing smoking was one that talked about how much big tobacco benefited from people smoking. And so if you want to rebel against somebody, don't rebel against your parents for telling you not to smoke. Rebel against big tobacco because they're making the money. So we'll have to be creative and innovative, but we definitely need to make sure that this message permeates at every level of our society, and that includes teachers, sports coaches, parents, and others. So it goes across our entire community, and I'm sure there are others as well. But at the end of the day, communication and education about the risks of addiction and the possibility of overdosing is so essential, and we can't over communicate that risk. So another area that I think we can be very active in helping to prevent both the initial use of opiates and then opiate use disorder, or at least help people who have it, is by what I call community intervention and action. So one of the key things that we've learned is that there's a lot of adolescents and teenagers who start with their parents' prescriptions. Right? They go into the medicine chest, they find something that they want to try, and they like it. And so safe storage and then appropriate disposal of prescription medications, and particularly opiates, is essential. And everybody can play a role in that. I've got funded from the National Institute of Health to run a drug disposal program, and I've been running a pilot up until the time the COVID intervened, but we've been running a pilot giving out drug disposal pouches to individuals and trying to determine how effective that is as an intervention. The other thing that can be helpful is increased access to Narcan and training community members on how to both recognize an overdose and how to respond to it. So even people like the Surgeon General have recognized the increased need for the layperson, the average community member, to be familiar with Narcan and be able to help people who may be struggling with opiates and may have an overdose, and so others can reach out and help them. The other big thing is that unlike other diseases, opioid use disorder is one that people are very ashamed of. So they don't want to reveal that they're struggling with opiates. And it's not that it's the only disease. Alcoholism certainly falls into that category as well. But people with opioid use disorder often remain in the dark, and many people, sometimes people around them, don't realize that they're struggling with opiates until it's too late. And so we want to start to think about opioid use disorder like we think about other diseases, something people don't choose to get, but they get it nevertheless, and that when we know that somebody who we know or care about or love has a opioid use disorder, then we need to treat it as a medical issue and not a criminal one, and be empathetic. So there's a whole issue around stigma that is very important. And then there are other things like clean needle exchanges, providing more access to blood testing um, to prevent Hep C infections and the like. So the third area that I think is important is one of regulation and advocating. So we know, even though we've made progress in the United States with prescribing, we're still vastly overprescribing opiates. We're still prescribing far more than any other country does by any measure, per capita, in total, etc. So we need more education, safer prescribing practices, less prescribing of opiates. So, and that is something that I think we have to advocate for. Advocate for it through legal means, advocate for it through public health communication, whatever it is. We need to make sure that prescribers are prescribing less opiates as a general rule. I'm not saying every prescriber or end of life, palliative care, cancer treatment is certainly appropriate, but general practitioners of dentists and family health care, there really is an issue with the overprescribing. So the other thing that we know is that some states, and right now it's up to 16 states, have passed a right to know law. We need that in every state. And the right to know law, as I've mentioned, is that the prescriber has to have a conversation with the person they're prescribing it to or their parent about the potential for addiction, dependency, potential for overdose, and discussion of alternatives. The other thing I'd like to see happen is if someone is given an opiate prescription, they're also co-prescribed naloxone. And that's both a safety issue and it's a communication issue, because if I give you naloxone, which is the antidote to an opiate overdose, first of all, it lets you know that about the risk of having an opiate and that you're taking yourself or bringing it to your home. And secondly, if somebody does overdose from an opiate prescription, then we have that intervention more readily available. So right now, New York is the only state that funds the co-payment of naloxone. They've set up a what's called an NCAP program, naloxone co-payment assistance program. So if you're a resident of New York and you go in to pick up naloxone, then the state will cover the co-payment. So you walk out without a co-payment. So in Massachusetts, New Hampshire, and most other states now, there is anybody can go into a pharmacy with or without a prescription and get naloxone on the spot. So that there have been standing orders put in place across the country that allows pharmacists to dispense it without a prescription. And that's because of the public health emergency related to this epidemic. And then the other thing that, and this is really going to require people who have a vested interest, like yourselves, future acupuncture professionals, and you're going to have to advocate for increased coverage of, I'll call them alternatives in quotation, but particularly Chinese herbal medicine, acupuncture, and other things that insurance companies will pick up the cost of that. Because if you think about it, they cover the cost for opiates. It probably makes a lot more sense, a much lower risk, and no known side effects to other treatments. And we have to become more balanced in our approach to covering these types of options. But it's not going to happen without the energy and the fight from people who have a vested interest in making it happen. So we talk about the whole spectrum of alternatives to opiates for helping to manage pain and basically to prescribe less opiates. I think there are several things that have to happen, but at the top of the list are we have to educate healthcare providers that these options are available. So I ask people all the time, physicians, pharmacists, and others, how much do you know about acupuncture or other alternatives, physical therapy, and so forth? And generally speaking, The answer is that they don't know a lot. And so I think it's really important that people who want healthcare providers to start to use different alternatives to opiates have to really educate and communicate with healthcare providers that there is an alternative that works for certain things. So that's number one. And also, there has to be an increased campaign to communicate with the public. So I know both steps 1 and 2 are happening, but they're not happening fast enough, and they're not happening at a rate that they should be happening. So we have alternative solutions to opiates. Now, and so here's a short list here: acupuncture, psychotherapy, meditation, massage, tai chi, yoga, physical therapy. All these things should be used either as a complement or ideally as an alternative to giving high-risk pain relief through opiates. So the Cleveland Clinic, which is often held out as one of the best-run healthcare organizations in the United States, is trying to move towards an opiate-free surgeries. So I don't know that they'll ever get there 100%, but if you think about the first reaction of most surgeons for surgery over the last decade was to write an opiate prescription. So now the Cleveland Clinic is training their healthcare providers about alternative pain management therapies. And if they're going to give an opiate, to give less and lower dosage. So when we think about, going back to the 4 things I've talked about, these are the 4 areas that I think can help us prevent either initial use of opiates and or people getting developing opioid use disorder. So there's another a book I came across when I was looking at strategies for prevention that I thought had some good points. So it's called Pain Management and the Opiate Epidemic: Balancing Societal, Individual Benefits and Risks of Prescription Opiate Use. And so they've talked about strategies for restricting supply. So one strategy they've recommended is improved access to drug take-back programs. So I'm very familiar with drug take-back programs. There's really 3 ways of doing it. One is to have these drug take-back days that you may have participated in your community. Many communities have them. They're run by the DEA. They're usually once or twice a year, and you go to a central location and you bring back any unused prescription. There's also drop boxes that exist in most communities' police stations. And then the third is the intervention that I've been working on with a bunch of public health officials in Massachusetts, which is to provide these drug disposal pouches to individuals. And I'll share more about that later in the semester. So that certainly is a means to help help with the prevention aspect. The other, it kind of reiterates some of the things that I talked about: establish comprehensive pain education materials and curricula for healthcare providers. Okay, so healthcare providers need to know about addiction. Facilitate reimbursement for comprehensive pain management. Okay, so, and that's both pharmacological and non-pharmacological treatment modalities. Improve the use of prescription drug monitoring data for surveillance and intervention. So prescription drug monitoring programs are essentially these have been put in place in every state now. And essentially what happens is if you present with an opiate prescription at a pharmacy, then and actually I'll back that up a step. If your doctor or prescriber is writing you an opiate prescription, they should check a database called the Prescription Drug Monitoring Program to ensure that you don't have other opiate prescriptions, because what had been happening was that people were doctor shopping and having multiple prescriptions. So now to help with that doctor shopping, doctors at the first step and then dispensers at the second step are required to check in this database called the Prescription Drug Monitoring Program. It's been very helpful in reducing opiate prescriptions, but not so helpful in reducing the use of opiates themselves. because people who are addicted to opiates, if I don't get a prescription, I'm going to find other means, and that's the illicit market. And then strategies for reducing demand. So evaluate the impact of patient and public education about opiates. Okay, so again, getting back to some of the points that I made earlier, expand treatment for opiate use disorder. So talk a little bit more about that in weeks 3 and 4, but basically we do have effective treatment for opiate use disorder. Unfortunately, only about 10% of people with opiate use disorder actually avail themselves to treatment, and that is at least in part, if not in large part, due to the fact that it's difficult to get into treatment. There's a limit on how many patients prescribers of medicated assisted treatment can see, and there's also some issues with insurance. And then improve education and treatment of opioid use disorder for healthcare providers. So we'd really like to see more people become waivered. So this may be surprising to some people, but in Massachusetts, as of last summer, because I did a study and I did some research with the DEA, there were roughly 48,000 prescribers of opiates in Massachusetts, and only about 5,000 prescribers of medication-assisted treatment. So in Massachusetts, actually, it's a much higher percentage than the country overall. The country overall is moving to about 3 or 4%. We're at about 10% in Massachusetts. But you think about that, for every 10 prescribers of opiates, there's only one prescriber of somebody who can help somebody wean themselves off of that. And then we have to remove barriers of coverage for medication to assist with opiate use disorder. All right, so that I think is some of the key things that I want to talk to you about. I want to show you some of the things that I'd like you to read and or view as part of your understanding and part of our discussion on how to prevent the access to opiates and or developing opioid use disorder. Okay, so if you go into the folder called Prevention Strategies, I have some materials I'd like you to review. One area that I'd like you to review is what's going on in Rhode Island, because Rhode Island is often held out as the model state for dealing with the opiate healthcare crisis, and they're doing a lot of good things. So there's a short talk given here by the governor. And that's Gina Raimondo, and she's really led a lot of very strong initiatives in. And also, I found their action plan. So here's the Rhode Island Overdose Prevention and Intervention Task Force action plan. And if you thumb through this, you're going to find a number of really interesting things that they're doing. Will give us more ideas in terms of what can be done to help with this crisis from an intervention and prevention perspective. So, they mentioned the prescription drug monitoring program, access to naloxone, increased access to medication-assisted treatment, and then increased access to recovery services above and beyond that. So lots of good ideas here. And then there's a short video here that I found that I really thought was quite compelling. This doctor, her name is Kelly Pfeiffer. If you click on this button here, talks for about 8 minutes about how she was part of the problem, that she used to prescribe opiates on a regular basis, and now she realizes that probably that definitely was something that she should not have done to the extent she did. And so she talks about her learning experiences and ways that others might prevent the same mistakes. And then there's a couple of other things here that, if you click on them, will be helpful in terms of developing some understanding of strategies to prevent the opiate epidemic from proliferating. Okay, so those are the basic things that I wanted to talk about with regard to the week 2 prevention discussion. So I look forward to your contributions on the discussion board. And as always, feel free to call me, text me, or email me with any of your questions or suggestions. Thank you very much.